Go ahead and share your screen, Dr. Kiramijyan.
Hello, everyone.
Sorry, it's perfect. Sorry.
Hello, everyone. My name is Sarkis, Kiramijyan, Interventional Structural Cardiology. I'll be speaking about management of coronary artery disease, diagnostic approach, interventional and surgical therapies. Thank you. I have no relevant financial relationships to disclose. Outline of the talk, I will include coronary artery disease as an introduction, chest pain epidemiology, introduction of chest pain, evaluation and triage, current ACC and AHA guidelines. I was asked to tailor this talk to the primary community a little bit, including non-invasive ischemic evaluation, comparing the indications, appropriateness, and value of diagnostic cardiac tests. Then we will speak about invasive ischemic evaluation, interventional therapies and techniques, surgical therapies, and recommendations on antiplatelet management. Epidemiology of chest pain, about 8 to 10 million of US emergency department visits per year. Among top 2 reasons for ED visits in the US, the other one being pulmonary etiology, pulmonary causes. Cardiac etiology accounts for about 1/3 of ED visits for chest pain. Other most common causes of chest pain in outpatients are actually musculoskeletal, 1/3 to 1/2 of patients, and gastrointestinal, the other roughly 10 to 20% of patients. Most common causes of chest pain in the ED, it's broken down by the ACC with age groups and quartiles, 18 to 44 years old. On the left, as you can see, non-specific chest pain is the most common etiology, and this includes mostly musculoskeletal chest pain. And then you have the 45 to 64-year-old age, where it's still non-specific chest pain throughout. However, you can see that coronary atherosclerosis is the second most common, is actually more common in this age group, 45 to 64, and it gets more common as you go to 65 to 79-year-old, and more than 80, greater than 80-year-old patients have more precedence, more incidence of coronary atherosclerosis as the cause of chest pain. So as the patient gets older, the etiology of chest pain would be more likely to be cardiac. Chest pain facts versus fear. More than 50% of ED patients presenting with chest pain receive comprehensive cardiac evaluation, including labs, non-invasive imaging, or observation. Yet less than only 10% of patients presenting to the ED with chest pain are ultimately diagnosed with ACS, acute coronary syndrome. Only 1.5% of patients presenting with to their primary care physician with chest pain will have unstable angina or ACS. And also about 1.5 to 2% of patients with acute MI are unrecognized at ED evaluations. Therefore, there's a discrepancy and therefore a burden of high cost. And the conclusion is that we need more improved and optimal chest pain evaluation and triage and management. Next. ACCHA recommendations for defining chest pain. This is the latest guidelines on evaluation of chest pain, 2021 ACCHA guidelines. Class 1 recommendation, initial assessment chest pain is recommended to triage patients effectively on the basis of likelihood that symptoms may be attributable to myocardial ischemia. Also, class 1, chest pain should not be described as atypical. This is a new change for the guidelines this year, and the chest pain is no longer recommended to say atypical on the evaluation of the physician, because it is not helpful in determining the cause and can be misinterpreted as benign in nature. Instead, chest pain should be described as 1, cardiac, 2, possibly cardiac, or 3, non-cardiac, because these terms are more specific to the potential underlying diagnoses. So this is a change in the guidelines. So variable index of suspicion for ischemia, this includes anywhere from high suspicion on the left side of the screen to low suspicion on the right side of the screen as a presenting symptom. And high suspicion symptoms include central pressure, chest pressure, squeezing, gripping, heaviness, tightness, substernal. It is exertional, stress related, and it comes on for a few minutes and gets worse with time. If you go down the spectrum here, then you can see lower suspicion of chest pain all the way to stabbing, aching, right-sided pain, tearing, ripping is more aortic dissection, or burning is more GI, esophageal, sharp, lasting seconds, pleuritic, changing with breathing or movement or positional. That's less of a suspicion for cardiac etiology. History of chest pain, patient with chest pain, focused history that includes characteristics, duration of symptoms, relative to presentation, as well as associated features, and cardiovascular risk factor assessment should all be obtained. This is highly important. Just on subgroups, a couple of things on subgroups. Women who present with chest pain are at risk for underdiagnosis. Potential cardiac causes should also be considered because women usually present with atypical non-specific symptoms, and they include certain symptoms including nausea, vomiting, headaches, or neck pain, or dizziness, or shoulder pains, shortness of breath. So women don't tend to present with the typical classic symptoms that we know of, and therefore they can be underdiagnosed, and a high index of suspicion is needed in this population. In women presented with chest pain, it is recommended to obtain a history that emphasizes accompanying symptoms that are more common in women with ACS, which I explained. In patients with chest pain who are greater than the age of 75 years old, ACS should be considered when accompanying symptoms such as shortness of breath, syncope, acute delirium, or unexplained falls. So the elderly present in different ways as well. So a high index of suspicion is needed. 5 key components of a chest pain evaluation. Very important. These are the sort of 5-finger rule we say in cardiology for chest pain evaluation. That includes history, specific history and detailed history, physical examination, ECG, consider serial ECGs if the suspicion is high. Chest X-ray is important. In the ER, labs including troponin I or T, depending on the local expertise, and serial troponin are recommended as well to rule out MI or to assess the severity of it and the timing of it. Chest pain characteristics and corresponding causes, nature of this. So this is part of the history, very important nature of the chest pain. Anginal symptoms, retrosternal discomfort, usually pain, discomfort, heaviness, tightness, pressure, constriction, squeezing. And usually the onset is within minutes. It gets worse and intensifies over minutes. Sometimes it's relieved with nitroglycerin or rest, but nitroglycerin is somewhat difficult to assess because other esophageal or GI etiologies can also be relieved with nitroglycerin. So it's non-specific. Onset and duration. Anginal symptoms gradually intensify over a few minutes. Sudden onset of ripping chest pain. Radiation is more of a aortic etiology. Fleeting chest pain lasts within seconds, is usually non-ischemic, usually related to muscles or muscle strain or sprain, neurologic causes, and not really ischemic. Location radiation, pain in the substernal region is usually typical, radiates to the left shoulder, can radiate to the neck, as hence the old term angina, meaning neck pain. So chest pain etiology from the myocardium can also radiate to the neck. Usually if it's radiating to the belly or in the umbilical region, it's usually non-cardiac. Severity, ripping chest pain is usually due to aortic causes. And then you look at precipitating factors physical exercise or emotional stress can bring it on and worsen the chest pain. Occurrence at rest or minimal exertion usually indicates cardiac etiology. Positional chest pain is usually non-cardiac, usually musculoskeletal if it's position. If it's changing with position, arm movements or breathing, respiration, it's usually non-cardiac. Relieving factors, nitroglycerin is not necessarily diagnostic of ischemia, should not be used as a diagnostic criteria because GI related issues can also be relieved with nitroglycerin. The associated symptoms, common symptoms associated with myocardial ischemia include, but not limited to, dyspnea, palpitations, diaphoresis, lightheadedness, presyncope, upper abdominal pain, which could be sometimes due to lower myocardial MI, such as in the inferior wall that is close to the diaphragm, and that pain can radiate, that region of pain can radiate to the upper epigastric region. Symptoms are left or right-sided chest pain, stabbing chest pain, discomfort in throat or abdomen may occur in patients with diabetes, women, and elderly. So atypical signs in the diabetic population in women and elderly, as we discussed. Physical examination is key. Diaphoresis, tachypnea, tachycardia, hypotension, crackles, heart failure signs, these signs are typical for high-risk features in ACS. Someone that potentially has a PE could have tachycardia, dyspnea, hypoxia, and that's more of a PE etiology. Aortic dissection, someone with connective tissue disorder, someone with potential aortic dissection, widened mediastinum on chest X-ray, pulse differential in the arms, in the radial arteries, or blood pressure differential in the arms. So some of these symptoms are important to note. AR can happen in 40 to 75% of patients with type A dissection. So this is more aortic dissection. Esophageal rupture is different. Emesis, subcutaneous emphysema, pneumothorax, decreased breath sounds on one side versus the other. So these are physical examination key points. It's non-cardiac. You could have valvular etiology, that's important. ASAR, need to have a high index of suspicion. And then you have pericarditis, myocarditis, usually associated with fevers. EKG is sometimes diagnostic. Friction rub with pericarditis, esophagitis, epigastric tenderness, pneumonia is different, localized to fever, and infectious etiology. Then you have pneumothorax, condocarditis. Costochondritis is a typical presentation in the ER, tenderness in the costochondral joints that is reproduced on exam, finger examination, and pressure on the chest, reproducible chest pain, usually non-cardiac, almost always non-cardiac, if that is the actual chest pain that brought the patient to the ER. And of course, you have infectious causes, pain with herpes zoster is related to dermatomal distribution and triggered by touch. So pretest probability is very important when we assess chest pain. This is what we do as cardiologists, especially in the clinic. When patients come in with chest pain, we look at their age, their symptoms of angina. Is it typical or atypical? These are the older criteria. That's why they use atypical and typical. And now it's recommended to use cardiac or possibly cardiac or non-cardiac. But the older data has a lot of robust outcomes and publications. So it's very important. This is the Forrester diamond plot where you look at the age of the patient and gender. If they're young, they have typical symptoms. They could have intermediate probability of having obstructive CAD, usually means more than 70% diameter stenosis on angiogram. And so these patients you would want to potentially test further. If they're a woman, a young, and non-anginal chest pain, they have a very low pretest probability. So those patients don't need further testing, for example. And you could look at the high probability groups. These are the older people, more than 60, with typical angina, So they have a high pretest probability of having obstructive CAD. So this is how we sort of assess in our minds how we're going to approach the management and the workup for chest pain. Pretest probability also is important to note that pretest probability has added another stratification of testing and stratification of pretest probability, and that includes the coronary artery calcium scan. And if the coronary artery calcium is high, the pretest probability goes up. So this is a nice test. This is just a CAT scan that only assesses coronary calcium and is not with contrast. It's low radiation, and it's a very good prognosticator of coronary artery disease and outcomes. Features that are not characteristic of myocardial ischemia, we mentioned those: pain that's reproduced or with movement or palpation on the chest pain that lasts for many hours and it's consistent, lasting the whole day, persistent, usually is non-cardiac. Very brief episodes of pain, I should say non-ischemic. It could be cardiac, for example, pericardial effusion or pericarditis or myocarditis. Non-ischemic is the key. Consistent chest pain persists throughout the day is non-ischemic. Very brief episodes of pain that last a few seconds or less, sharp pain lasting seconds and fleeting after a few seconds, non-cardiac. Pain that radiates to the lower extremities, non-cardiac usually. Features that are not characteristics continued. Primary location of discomfort in the middle or lower abdominal region is usually non-cardiac, unless it radiates to the chest. Pleuritic pain, sharp or knife-like, brought on by respiration or cough, usually non-cardiac or non-ischemic. Pain that may be localized at the tip of the finger by palpation on the chest, particularly over the left chest region, could be costochondritis or musculoskeletal etiology. So it's important to note all these physical exam findings. So when we assess chest pain, especially as an outpatient or in the ER, ECG is a major tool. That's how we diagnose STEMI. That's how we can diagnose pericarditis. We can diagnose non-STEMI based on troponins, of course, and the fact that there are ST depressions or T-wave inversions. Sometimes we have non-diagnostic ECGs. We get serial ECGs to improve our accuracy and diagnostic specificity and sensitivity. But sometimes even STEMIs may not show up on ECGs. If they are posterior STEMIs, for example, they're more difficult or very lateral, posterior in the circumflex region, or a very big RCA. And sometimes it's recommended to do posterior leads to diagnose these in certain situations. When it says leads V7, 8, 9, these are posterior leads. Sometimes arrhythmia is a cause of chest pain as well, and ECG is highly helpful. Chest X-ray is mandatory. As you know, it's important to note the chest X-ray to make sure you rule out other causes, such as pneumothorax or pneumonia, pulmonary issues, thoracic issues, aortic issues. So chest X-ray is mandatory. Likelihood that signs and symptoms represents ACS, acute coronary syndrome due to coronary artery disease. I will go over the high likelihood causes. As we mentioned, chest pain that is typical. Sometimes there's heart failure involved, pulmonary edema, transient ST changes, T-wave inversions, dynamic changes, changes ECG to ECG. Those are usually ischemic related. Elevated troponins, of course, are ischemic related. So these are the important high likelihood causes of ischemia. Chest pain, appropriate cardiac testing. So as you can see the pyramid, this is on the latest guidelines. People with ACS, of course, acute coronary syndromes, which include unstable angina, non-STEMI and STEMI, of course. These patients, of course, get invasive coronary angiograms as the primary tool for diagnosis and treatment. If they're high risk, unstable angina, but not MI, meaning not a non-STEMI or not a STEMI, these patients potentially can also get angiogram because they have high-risk features. And we discussed some of the high-risk features. Sometimes if they're an outpatient, these patients with high-risk or intermediate risk features can have stress testing or cardiac CT to assess for coronary disease. If they're lower risk, intermediate, lower risk, they can have coronary artery calcium scans potentially as a diagnostic tool and a prognostic tool. And patients that are very low risk in the ER usually get no testing. Asymptomatic patients, of course, usually get no testing. Short-term risk of death. These are the high-risk symptoms like we talked about. So when I mentioned high risk in this region of the pyramid, high-risk features include accelerating tempo of symptoms in the preceding 48 hours, worsening chest pain in the past 48 hours, prolonged chest pain more than 20 minutes, or pain at rest, heart failure symptoms, pulmonary edema, new mitral regurgitation, rubs or gallops, RALs, hypotension, not rubs actually, RALs and hypotension. These are high-risk features. On the EKG, ST changes, new bundle branch block, sustained VTAG, resting angina. These are high-risk features of mortality, early mortality. Elevated troponin, of course, high-risk feature. So these patients, we have to potentially work up quicker. They will potentially need cardiac catheterization quicker. And these are the early invasive patients, which we will discuss. Patients that come in with chest pain, appropriate testing is important. And if it's a low likelihood of CAD, potentially sometimes we can do a coronary artery calcium scan or a stress test. If they're intermediate to high risk patients, we do prefer stress test or cardiac CTA, CT angiogram, which is a CAT scan that also has contrast, which is an angiogram as well. Intermediate to high risk patients, stress test, of course. These are the likelihood for CAD, so stress test or cardiac CT. And how do you favor one versus the other? Cardiac CT is favored usually in the younger population to rule out obstructive CAD. It has a high specificity sensitivity, but it's not a functional study. It is an anatomic study. So if we're looking more for a functional study, ischemia guided study, we usually do those for the higher likelihood populations, high to intermediate to high populations, advanced age, possible prior CTA that's not conclusive. And if we're looking for more robust findings, such as scar, fibrosis, PET scan or CMR is more sensitive for those. And some of the qualities and positive features of the tests are listed. Exercise treadmill test is the least sensitive and specific test, and it's preferred usually with a imaging component, either a nuclear component or an echo component, to improve its sensitivity specificity in the right population if there's intermediate to high likelihood. If it's low likelihood, exercise treadmill test should suffice. Then you go to PET and stress MR if you're looking for quantitative flow, LV dysfunction and scarring, and they have more features, diagnostic features. Chest pain algorithm, chest pain, if it's acute, of course, continue with the discussed diagnostic tools that we discussed already. If it's not acute, then there's more of a stable syndrome. Potential causes are important after the ECG is done. Of course, STEMI diagnosis is key. We talked about the other non-cardiac diagnoses, and we follow the guideline for each once we hone down on the diagnosis on presentation. TT is very important. Echo can give us a very good idea of wall motion abnormalities and potential etiology for ischemia and patients that are sort of inconclusive in the ED. Echo can also help as well, class 1 indication, to get an echo for potential cardiac etiology. Risk stratification for ACS, of course, history and physical exam. Then we potentially go on to possible ACS, low risk, intermediate, high risk. We talked about the high risk features, and we have specific scores that we use for patients that would qualify for high risk. And We'll talk about those. This is sort of an illustration of a range of coronary disease, gauging from normal coronaries all the way to fatty distribution and macrophages bringing in fatty cells and fatty streak formation, distributing in the lining of the lumen, in the artery, and with time, fat accumulation, cholesterol accumulation, potential bursting of the plaque causing MI or STEMI or non-STEMI, and then more stable syndromes where it's more calcified. And these patients with more stable syndrome actually are the ones with less presentations of STEMI. The ones that have sort of less stable plaque, meaning less calcified plaque, more cholesterol-rich plaque. These are the patients that have a higher risk for ACS versus the ones that have more stable calcified plaque. Going forward, actually, the evidence shows that patients that have less than 50% diameter stenosis are the ones more likely to have STEMI rather than the ones that have more than 50% diameter stenosis, because usually the latter has more stable plaque, more calcified plaque, versus the former has less stable, less calcified, more cholesterol-rich plaque, more soft plaque, if you will. Normal artery here, and you can see endothelial dysfunction occurs. This is a dogma of coronary disease. Endothelial dysfunction can occur for a number of reasons. Any disease can cause endothelial dysfunction, anything from diabetes to hypertension to family history can cause endothelial dysfunction. Diet, of course, any number of risk factors. And when endothelial dysfunction happens, the cholesterol is deposited in the lining of the endothelium, and we call this fatty streak formation. We can have a stable fibrous plaque, potentially calcified. Sometimes you have soft plaque, which could rupture and cause a thrombus. And this is what ACS is, acute coronary syndrome, thrombus formation. Anything from unstable angina to STEMI can present this way. Going forward, coronary anatomy, as you can imagine, left side of the coronary LAD and circumflex provide about 60 to 65% of the flow to the myocardium. Just an illustration here. Going forward, as I mentioned, ACS is a range of presentations. It could be from an unstable angina, which is negative troponins, of course. Unstable angina can be ACS. NSTEMI is ACS, of course, and NSTEMI can cause non-Q wave MI or even Q wave MI. So STEMI is the most common cause of Q wave MI, but also non-STEMI can cause Q wave MI, meaning full thickness damage to the myocardium. And of course, you have non-cardiac etiologies. This is a classic illustration of ACS and the range of presentations from unstable angina to NSTEMI to STEMI. Invasive coronary angiograms, as you can see here, coronary angio. You can see on the left. That there's disease in the mid RCA. As you can imagine, that's a very tight disease and very severe high-grade lesion. And then you have a distal coronary angio and distal coronary RCA disease, which is also very tight, about 90% here, 95%. Then you have coronary angiogram on the right side of the screen, and you have proximal LAD that's showing severe high-grade narrowing. So these are specific angiograms that are potentially worrisome, of course. And these are what we see sometimes with STEMI or NSTEMI or unstable angina, just as illustrations. TIMI risk score is important. This is how we assess risk status. TIMI risk score for unstable angina or NSTEMI. The higher the points, the more likelihood of death in the first 30 days. And we assess this by age, risk factors, prior disease, ST deviations, high-risk features of angina. Aspirin use is actually included. Patients that use aspirin, higher risk for mortality because they're presenting this way. and they're presenting with unstable angina or NSTEMI. Elevated biomarkers, of course. So the more points you have, the more risk for 30-day mortality. GRACE score is another score we use typically, and this includes serum creatinine, which is also an additional marker of increased mortality. The more points accumulated on presentation for non-ST elevation ACS. This includes unstable angina and non-STEMI. So the more points, the more chance for death. This is another score, ER score, heart score. It's published from Europe, and the heart score essentially has the same factors of history, ECG, age, risk factors, troponin level, and the lower population, which is a 2.5% MACE rate, usually can be discharged home safely. If it's a higher risk score, these patients will, of course, be admitted and worked up more. This is sort of the pathway. Low risk can have an early discharge. This is to save costs and expedite the workup of chest pain in the ER. And if it's a more higher heart score, then more testing and cardiology consultation is needed. We sort of talked about these. It's important to note that people with chest pain with no known CAD, if they've had prior testing, they may need more advanced procedures for diagnostic testing, meaning cardiac CTA or invasive angiogram. If they haven't had prior testing, you consider stress testing for these patients if they qualify. So it's just a way, an algorithm to guide the physician for testing. Patients with intermediate risk. So these are the intermediate risk population that, of course, low risk is much easier to rule out. High risk, of course, we usually go to invasive protocols, but the intermediate risk patient, there's a lot of range of presentation, so it's important to stratify them better in order to know, is a stress test appropriate or a cardiac CT appropriate or a invasive angiogram. So if they have high risk features of angina, then invasive angiograms are recommended. If they have low risk features, of course, like we talked about, then less invasive tools are recommended first. Stress testing versus cardiac CT, where we talked about more physiologic versus anatomic, based on the presentation and age and risk criteria. Cardiac testing, intermediate risk patients, as you can see, cardiac cath is the more sensitive and specific, but then you have nuclear stress tests, which is a physiologic test, which is more sensitive than exercise test alone. Stress echo is also more sensitive specific than exercise test alone. Usually most cardiologists will do some sort of an additional imaging test in addition to the exercise stress test if they can exercise. Patient cannot exercise, then we recommend more pharmacologic stress testing, which includes a nuclear, potentially with a vasodilator, or a nuclear test, or a dobutamine stress echo, or PET scan or CT scan, or CT FFR, which is a new tool. Actually, it includes the anatomic testing and the physiologic testing, which is a great tool, but it's not available at most hospitals, which will be available in the future. But it's a great test where you can potentially do a CTA, CT angio, and also use an FFR, which is a artificial intelligence driven algorithm and AI driven algorithm. And it's a pretty sensitive, specific evaluation physiology in addition to the anatomy from the CT. Warranty period. People sometimes ask me, what's the warranty period? It's changed. Before it was 5 years. Normal coronary angiogram or a normal cardiac CTA has a 2-year warranty now per guidelines. Stress testing, of course, taking into account that it's a normal stress test, it's a 1-year warranty. Just in the interest of time, non-cardiac chest pain, there's a huge list of non-cardiac chest pain, so we have to be careful about assessing the physical exam and history. So it's worth mentioning INOCA, ischemia with no obstructive CAD, and these are patients that have microvascular disease. There's a lot of these patients, especially women, non-cardiac, they are cardiac, but non-epicardial coronary disease, meaning the epicardial arteries are clear, they're not obstructive, but the obstructed regions are the microvasculature, the capillaries. And the way we diagnose these, usually they have slow flow in the epicardial vessels. We can see them on angiogram. We can check coronary flow reserve on angiogram. We could also check we can use certain provocative tests like acetylcholine to reproduce the symptoms of spasm, for example. If it is spasm, this could also present as INOCA. Anything that's non-obstructive in the epicardial coronaries, meaning spasm or distal vasculature, distal capillaries. If the patient is a patient that potentially can have stress PET or stress MR, it's a good way to diagnose microvascular dysfunction with microvascular myocardial blood flow reserve, and that's done with PET testing, which is a good diagnostic test for that. Usually we don't have that at the local hospitals, so we can diagnose these syndromes by an invasive route rather than by a highly complex diagnostic route, technologically complex. Most hospitals don't have the stress PET or a specific CMR algorithms, because these are specific algorithms for myocardial perfusion, blood flow perfusion tests. Forward, we mentioned that. So ischemia-driven, early invasive versus ischemia-guided. So if the patient has high-risk features, which we talked about, refractory angina, signs of heart failure, hemodynamic instability, VTAC, recurrent angina, long-term angina, long-lasting angina, these patients usually will end up having immediate invasive tests, meaning angiogram, for unstable angina. Of course, it's an MI, then of course it's immediate, usually, at least within the first 24 hours, if high-risk features are not present. If high-risk features are present, usually we like to expedite and do it quickly, because chances are they have more obstructive, high-grade lesions. Revascularization with PCI or cabbage. So in patients that have an optimal heart team approach, this is key to assess with the heart team approach, because interventional cardiology, cardiac surgery is involved, and heart team approach makes for better decision-making process. And of course, the patient factors, cultural beliefs are taken into account when deciding, are we going to proceed with the PCI or cabbage route? So just to mention, just to go back one slide, it's important to note that patients that have diagnostic testing, stress testing, or cardiac CT, patients that are found to have at least moderate to high risk, moderate to high burden of myocardium at risk, that can be noted on nuclear stress testing or PET testing or stress echo testing. If it's moderate and above, those patients usually go on to have a diagnostic cardiac catheterization. If it's low burden of ischemia, then those patients are usually treated medically, because there's no evidence that suggests cardiac evaluation or revascularization will benefit these patients. So if these are moderate to high burden of ischemia, then we proceed with the more invasive testing. Those are the patients with the diagnostic tests, stress tests, or CT as an outpatient. These are the patients that present with unstable angina and ACS. So these patients are treated differently, usually with angiograms in the hospital. And then we decide, based on the angiogram and the diagnostic strategy, what are we going to do for the patient? How are we going to help the patient? What's the best strategy for the patient? What's the most durable for the patient? So all these things are taken into account with the heart team, and then we decide, is PCI best or cabbage best? We'll review those. This is just the heart team approach, pre and peri-procedural and post-procedural management. It's a lot of post-procedural management, everything from cardiac rehab to smoking cessation, so on and so forth. Factors, consideration by the heart team, any number of cardiac issues, including left main disease, multivessel disease, highly complex lesions, comorbidities, procedural factors, all these, the patient factors, cultural factors, religious factors, all these are taken into account to decide what is the best strategy for revascularization. Is it a complex PCI versus a cabbage? Features of increased coronary disease complexity. Patient has left main or proximal AD artery lesion, chronic total occlusions, These are the complexities of the coronary anatomy itself, which helps us decide which is best for the patient. Is it going to be CABG surgery, multivessel CABG, or is it going to be a high-risk complex PCI? So chronic total occlusion, trifurcation lesions, three-branch lesions, where the branch, for example, three branches, usually left main with three branches, including circumflex, ramus, and LAD, or a LAD that has three branches. Trifurcation lesions, which are difficult usually with PCI, these are preferred for a CABG approach. Complex bifurcation lesions, heavy calcification, severe tortuosity of the vessels, aorto-osteal lesions, very origin of the vessel, diffuse disease, narrowed segments distal to the lesion, thrombotic lesions, thrombus formation. Lesion length is long, you would require long stents, for example. These are better for CABG surgery. So all these things are taken into account, and there's a syntax score, we call it, from the syntax trial, which I'll share with you. And this is how we stratify the patient to decide and to recommend which strategy of revascularization is best for them. STEMI care, we talked about STEMI care. Of course, we all know STEMI. Just to mention that STEMI requires primary PCI to reduce mortality. If PCI is feasible, if they're cardiogenic shock, class 1 indication for PCI. If PCI is not feasible, then CABG. If the patient is ongoing ischemia, of course, class 2A indication. These are the patients that have presented more than 12 hours after symptom onset. Symptom onset is late. They presented late to the ER. The level of recommendation goes down, still 2A if they're symptomatic. If they're not symptomatic and they've totally completed their PCI more than 24 hours, symptoms have resolved, usually it's a class 3 harm, meaning no benefit. And this is shown by the OAT trial, OAT trial. It's a very landmark trial. Patients that actually present late, have no symptoms after STEMI, it's actually harmful to try to revascularize them with PCI. So these patients are usually medically managed. Revasculate non-culprit artery at the time of the primary PCI. So if STEMI is done on the culprit artery and the artery is fixed, sometimes there's class 2B indication to fix a non-culprit artery at the time of the STEMI setting, the time of the same procedure, if that artery is a low-risk intervention. If the artery is a high-risk intervention, then it's recommended to stage that second vessel later on in the same index hospitalization or as an outpatient, if safe to do so. Revascularization to improve survival. This is very important here. New guidelines. So it's important to note revascularization to improve survival in stable ischemic heart disease. So these are the stable patients. So we talked about the unstable in ACS, that's unstable angina, NSTEMI, and STEMI. So these are now the stable ischemic heart disease. These are the patients that have chest pain, angina, but they've been stable at least for more than a month. And so these patients, we have to note, which are we doing? Are we improving survival or are we improving symptoms? So it's very important because not necessarily the two are mixed. Sometimes you may improve symptoms, but not survival. Usually I try to improve survival, also improve symptoms. But when it comes to PCI, it's not very clear because the evidence has been robust lately. And usually a survival benefit is not robust in the PCI population. And we'll go through that here. And patients with stable ischemic heart disease, multivessel CAD, we were talking about stable ischemic heart disease, non-ACS. Stable ischemic heart disease, multivessel CAD, that's appropriate for CABG. If the LV ejection fraction is low, this will improve survival. Patients with stable ischemic heart disease, multivessel CAD, if the EF is not significantly low, it's still a class 2 indication, 2A indication to improve survival. 2A meaning probably, likely will improve survival. It's reasonable to do so. Left main CAD, if the left main, CABG is recommended. In select patients with stable ischemic heart disease, left main stenosis for whom PCI can provide equivalent revascularization to possible CABG, then PCI is reasonable. This comes from the syntax trial. If PCI is reasonable, PCI can be done as a 2A indication. Multivessel CAD, patients with stable ischemic heart disease, normal EF, 2B indication. If patients with normal EF, significant stenosis, 3 major coronaries, with or without proximal LAD, 2B indication. So proximal LAD, it's still 2B. This used to be 2A, but the evidence has shown that even with proximal LAD disease, the survival is not very clear when it comes to revascularization. So 2B is the recommendation in this case. Patient with stable ischemic heart disease, normal EF, 1 or 2 vessels involved. Coronary revascularization is not recommended to improve survival. It's very important. It will, however, of course, improve symptoms, potentially symptoms of heart failure, improve symptoms of angina, and will reduce further need for revascularization. So these are benefits, of course, significant hard endpoint benefits, but they're not survival benefits. In patients with stable ischemic heart disease who have more than 1 coronary, not anatomically or functionally significant, meaning they're not 70% or greater, it's harm to do revascularization, as we know. PCI versus medical therapy is important now. So newer evidence coming from the ischemia trial and all of the meta-analyses incorporating the ischemia trial have shown that there's no benefit for survival advantage for PCI over medical therapy for patients with multivessel CAD. This is important. So all the meta-analyses have not shown a significant survival advantage for multivessel disease, meaning 3-vessel disease, for patients undergoing PCI versus medical therapy. However, it's very important to note that even though there is no hard endpoint survival benefit, there's a class 2A indication because many studies have shown that patients with stable ischemic heart disease. Now, just to remind you again, we're talking about stable ischemic heart disease. And STEMI, ACS, unstable angina, and STEMI are separate. There's clearly a robust survival benefit for PCI in that population because they are ACS. The stable patients are different. In patients with stable heart disease, multivessel CAD, appropriate for either CABG or PCI, revascularization is reasonable. So reasonable to do so, class 2A indication, to lower the risk of cardiovascular events in the future, such as spontaneous MI, unplanned urgent revascularizations, or even cardiac death. So this is important to note that revascularization with CABG or PCI reduces the need for subsequent urgent revascularization or rehospitalizations for acute coronary events. There's clearly a benefit, even though there is no survival benefit, where studies are powered for survival. But there's clearly a benefit for revascularization in these patients as well. Secret code here. Revascularization to improve symptoms, patient refractory angina, despite medical therapy. It's a one indication to potentially revascularize them to improve symptoms. So that's important too. Improving symptoms and quality of life is important, and just as important as improving survival, sometimes more important in certain populations, such as elderly, than improving survival. Improving quality of life is key. Just in the interest of time, we talked about revascularization, stable ischemic heart disease, which is preferred, PCI versus CABG. This is very important. If the coronary anatomy is very complex, we talked about the multivessel disease patients, the complexity of the coronary anatomy. If it's highly complex, and this is usually split up into tertiles, and this is coming from the Syntax trial, which the 10-year data was just published, 2019 actually, 1,800 patients, 1-to-1 PCI versus CABG, and they looked at outcomes, and the follow-up was great. 94% of patients completed follow-up, 10-year follow-up, and this is at the time where less robust stents, less than third generation, second generation stents, even first generation stents were used. The medical therapy was not optimal at the time. So there's some, of course, limitations of the trial because it's a little bit outdated now, 10-year-old, but suffice to say, it's a great trial for long-term follow-up. And the primary endpoint actually was not significant between multivessel disease for CABG versus PCI. So this is inclusive, multivessel and left main. So there's no difference in 10-year outcomes. There was a difference at 5-year outcomes actually between CABG and PCI, but the outcomes sort of came together as you followed out to 10 years. 10-year diabetes, no difference. This is important to note. However, we follow the FREEDOM trial, meaning the FREEDOM trial actually showed a difference, and we'll talk about that for diabetes and CABG. Left main group, no difference, 10 years versus PCI versus CABG. 3-vessel subgroup at 10 years. So this is the left main, no difference. So PCI is just as good as CABG, 10-year outcomes for left main disease. So there's a very important 10-year outcomes, very clear findings. 3-vessel subgroup, there's a difference. CABG is better, significantly better. However, this is driven by the high tertile of patients, meaning the more the complex the coronary anatomy, the syntax score is higher. The coronary anatomy is worse or more complex. These patients benefit from CABG more. If the coronary anatomy is less complex, more straightforward syntax, low syntax, intermediate syntax, then these patients do well with PCI versus CABG or CABG. Both do well. As you can see, no significant difference at 10 years. It's only for the very complex anatomies that CABG is indicated or indicated over PCI. 10-year conclusions, reassuring with respect to left main. Left main is equivalent with PCI versus CABG. 3-vessel disease with low to intermediate syntax score is equivalent with CABG. This is, of course, in spite of the fact that first-generation paclitaxel-eluting stents were used at the time for the syntax trial. So we have better stents now, better medical therapies. So hopefully we are better in line with CABG. Potentially in the future, the outcomes with PCI will be better than CABG, I think, in the future, as technology and the improvements on stent technology and medical therapy improve. And of course, now we have better testing, better physiologic testing, image-guided testing. So we're doing better when it comes to better assessing lesions and coronaries. So long-term follow-up is key, 10 years. Out to 5 years, the differences may have been more different between two groups, but they've coalesced and become more congruent out to 10 years. This is just a syntax score that takes into account other clinical factors. This is what cardiologists use in addition to the syntax score to better stratify patients. Patients with diabetes are key. So the FREEDOM trial, this is the FREEDOM trial. This is the biggest trial that includes diabetics and 3-vessel disease patients. And this is a huge trial out to 8-year follow-up. And it clearly shows that the patients with diabetes have better survival if they undergo CABG. So that's why patients with diabetes, we try to steer them toward CABG based on this major landmark trial, which is a FREEDOM trial. Even though the syntax trial at 10 years did not show a difference, the FREEDOM trial is a more robust and more powered toward diabetes patients, and CABG surely does better than PCI for multivessel disease for diabetic patients. High-risk PCI, it's important to note high-risk PCI nowadays, patients that are diabetic, high surgical risk, meaning high risk for complications or death with surgery, open heart surgery. They usually have revascularization done with PCI. So we're having more and more high-risk PCI in the current practice, and in a large observational registry that include high-risk patients with refractory ischemia, 5-year survival rates were similar among those treated with CABG and PCI. So we have good data for high-risk PCI versus CABG. So we cover this. Patients with previous CABG usually are in line to have PCI as a better route for revascularization. Assist devices are sometimes used. As you can imagine, patients with high-risk status, their EF is low, they have multivessel disease, their syntax score can be intermediate or high, even, but they're not CABG candidates, so they're prohibitive risk for CABG. CTO patients, severe valvular disease patients, low EF patients, sometimes we risk stratify them, and we may need to use LVAD support to revascularize these patients. We'll talk about LVAD, multiple LVADs. Balloon pump is the most used versus the Impella. It's most used as well. Actually, Impella has overtaken the balloon pump in major centers because it provides better cardiac support, better cardiac output flow, and better reduction of diastolic pressures, improvement in myocardial flow. Then you have the surgical pumps listed on the bottom. but these are the percutaneous pumps shown here, Impella and Tandem Heart. Tandem Heart's not very much used. Extracorporeal ECMO is used in certain centers for hemodynamic support. As you can see, ECMO has one of the best hemodynamic supports, including Impella 5.0, which is the latest one. But myocardial protection is great with the Impella because they reduce the LVEDP, improve myocardial flow. So sometimes the ECMO is used in addition to the Impella together in the same patient to improve hemodynamic support and myocardial protection. So for high-risk patients, what does the Impella do? It reduces end-diastolic volume, end-diastolic pressure, reduces mechanical work, wall tension, reduces microvascular resistance, and hence improving coronary flow. O2 demand is reduced, O2 supply is increased, myocardial protection. That's what we mean by myocardial protection, meaning reduced demand, increased supply, and the myocardium is happier. The flow through the transmyocardial space, the epicardial space, starting from the aorta down to the capillaries, is improved because the pressure is, the gradient is improved when you reduce the end-diastolic pressure. So these patients sometimes not without even PCI, they actually have better flow in the coronaries without even putting a balloon in there. So there's a trial ongoing for that as well. And they improve aortic flow and the output, cardiac output of flow. So cardiac power output is improved too. So these are the benefits over a balloon pump. Many studies have shown Impella provides more benefit, more cardiac support, more cardiac output than the balloon pump. Balloon pump back in the days did not show any survival benefit or any hard endpoint benefit versus medical therapy or versus no balloon pump when it came to revascularization for high-risk patients. But the Impella is a nice tool that actually shows clinical endpoints, positive clinical endpoints. And it's inserted from the groin. It's a 14 French sheath. It's a device with a pigtail ending. It suctions in the LV and ejects in the aorta. So suctions in the LV, ejects in the aorta. So it actually can stabilize the heart and reduce the workload on the heart, offload the heart, and improve flow to the other organs as well. And this is sometimes done with high-risk PCI patients. The trials have shown the Impella to have better MACE outcomes than the balloon pump. And we have better trials to show that the pronounced effects are actually in patients with extensive revascularization, meaning patients that have 3-vessel revascularization. The benefits are greater than the balloon pump in these cases. You can see from the PROTECT 3 trial, the Impella has more of an improved MACE, meaning major adverse cerebrovascular cardiovascular events. This is death, myocardial infarction, a stroke, or target vessel revascularization. So these outcomes in 90 days are much better than the balloon pump. So the Impella is gaining ground when it comes to high-risk PCI. PROTECT 3 sub-study, improved AKI. So it improves flow in the organs, improving flow in the renals. So it's actually much better than balloon pump. And the PROTECT 4 trial is going to include 1,200 out to maybe 2,500 patients using the Impella. And we're actually included as well at Adventist Health. I'm one of the co-investigators, and we will be enrolling these patients for high-risk PCI, complex PCI, and we at Glendale Adventist, and also to follow White Memorial Adventist. So this is a great trial, and this is going to be a landmark trial, national trial. So it's good that we're included as well. And then Impella, this is the RP. This is for the patients with RV failure, which sometimes is used. Going forward, coronary atherectomy devices are key. We use the rotablator, which is the drilling device. I'll quickly show this, and we can actually drill inside the artery over a wire with a diamond-tipped drill. Amazing technology. Then we have the Diamondback, which is the orbital atherectomy, and orbital meaning it rotates 360 degrees across an orbit, not rotational, but it rotates in an orbital fashion, and atherectomy for calcified coronary arteries. And each has their own advantage, depending on anatomy, specifically, depending on the size of the vessel and the tortuosity. extent of calcification, and of course, operator preference as well. But they're all these devices are preferential in cutting calcium and not damaging the tissue, the soft tissue, meaning the endothelium. And then we have laser atherectomy as well. Laser is used in specific cases where there's calcified lesions or in-stent disease, which is hard to clear or clean with conventional atherectomy devices. It uses a vapor bubble that actually modifies plaque even beyond the stent. So it's used in stent in grafts, sometimes used for lead extractions, highly volatile, highly energetic device, laser atherectomy. And of course, we use laser atherectomy in stents as I'm showing here. It's one of the main uses to use in stents because it's protected, the vessel's protected in stents, as laser is very volatile. It's not usually used in the virgin vessel. Unless it's a graft. It's used in grafts actually to clear out thrombus, which can be very useful. We use certain devices such as balloons, angiosculpt balloons, scoring balloons to modify plaque. This is all, we do all this with complex PCI, high-risk PCI, to make sure we have great improvement in luminal gain of the artery, so we can put a stent in there and dilate the stent and expose the stent completely, and make sure the stent is completely opposed to the walls. So stent expansion is the key for long-term durability and long-term patency. So we need to optimize the vessel with atherectomy if needed prior to implanting a stent. This is the whole purpose. And we can use specific angiosculpt or we have specific cutting balloons that have higher radial force versus normal balloons. We also have the lithotripsy balloon now, which has been shown to be very safe, and it actually emits ultrasonic waves across a balloon that's dilated inside a plaque, and it basically breaks the calcium in smaller pieces through energy transfer through the balloon, ultrasonic energy transfer that is specific for the calcium and does not affect the endothelium or the tissue. And this has become a mainstay of therapy actually for calcified disease. It's actually very safe. It's been shown to be very safe compared to conventional balloons. And there's no risk of embolization, minimal trace risk of embolization, and risk of damage to the endothelium is very low. It's preferential to the calcified regions, and it modifies the artery very well to prepare it for stent implantation. So we have great technology that has come about in the last 5 to 10 years. You can see with shockwave lithotripsy, the vessel, the calcified ridges are broken. So now when you implant a stent, the stent can expand and you have better luminal gain and better durability and patency for the vessel. IVUS is key. IVUS is always important when atherectomy is done to make sure that we have great apposition of the stent and expansion, and of course to size the vessel for the appropriate stent that you're going to use. Quick case presentation. We're running out of time. We just have a few minutes. 78-year-old man, CHF exacerbation on presentation, class 4 symptoms, poor, very significant past medical history, smoker, hypertension, hyperlipidemic, end-stage renal disease. EF is only 20 to 25%. And he's got class 3-4 symptoms of angina with minimal activity. He was actually turned down for surgery, declined for surgery because of high risk status, EF being 20-25%, thought that the patient may not survive the cardiopulmonary pump. So the patient was prohibitive risk, high risk, referred to us for complex high risk PCI, angiogram was done, severe 3-vessel disease, CTO of the LAD, completely blocked off 100%. Then you have disease in the circumflex, in the OM, and in the RCA. So 4-vessel disease, actually, technically. We call it 3-vessel disease because the OM is a branch of the circumflex classically, but the recommendation is to treat all 4 vessels if possible, and this is where the Impella comes in handy. Low EF, multi-vessel disease, more myocardial support, and more cardiac output versus the balloon pump, because as you can imagine, we work in the arteries, we do atherectomy, This patient had the impella placed. Extensive atherectomy was done in the LAD prior to stenting, and the LAD was opened, 100% blockage, to great results actually here with extensive atherectomy with the rotablator, rotational atherectomy, and fixing the RCA as well, including fixing the circumflex system as well. So this patient received multivessel PCI with impella support and did great. Without the impella support, probably couldn't have gotten this result because he would have dropped his pressures or had significant ischemia if the heart was not unloaded with the impella, especially during the rotational atherectomy, which was extensive. Patient was discharged home, hospital day 5, follow-up in clinic, NYH class 1 status, heart failure resolved, no angina at all. He was very happy. EF improved to 50%, double the EF at 3 months post-op. Amazing results here with the impella support, high-risk PCI. Case presentation number 2, 71-year-old man. Sometimes we get patients with vascular disease. He had class 4 angina, severe bradycardia, severe claudication, in the legs as well. EF 15-20%, found to have bilateral occluded iliac arteries. This patient was declined for CABG as well after finding out that he has severe left main disease and RCA is 100% occluded, severe 80-85% left main disease, probably 90% left main disease, actually 90% based on IVUS assessment, left main disease, and also patient had OEF, so he was declined for CABG, but he had no access for impella because both iliac arteries were occluded. So what do we do for this patient? We find alternative access. So we did a cut down with the surgeon, put a Gore-Tex graft in the subclavian artery, made space for the impella to be inserted from the subclavian artery, inserted into the LV, and also fixed the left main artery with a stent with great results, IVUS guided. So this patient did well. Discharged post-op day 6, came to the clinic at 2 months. EF is now 35 to 40%. And NYHA class 1 status. He's doing much better. Now he's planned for aortobiphem bypass surgery in the legs. Success story. So post-CABG, PCI and DEPT, post-CABG and PCI, usually dual antiplatelet therapy is recommended, usually for 1 year, unless it's stable ischemic heart disease and PCI is done, that's usually 6 months. But after about 3 months, if the risk is high for bleeding, we can stop the aspirin, only continue the P2Y12 inhibitor, and it's usually recommended 1 year post-CABG for graft patency. Aspirin for primary prevention is only recommended for patients with moderate or increased atherosclerotic cardiovascular risk. Usually we give it for diabetics. If they're low risk atherosclerosis, it's not recommended. Its 2B indication needs to be balanced with the risk of bleeding. Thank you. That is the end of the presentation. Thank you.